the anatomy, it has the layers are skin, platysma, the investing layer of deep cervical fascia, sternocleidomastoid muscle, then comes the carotid sheath, and the posteriorly prevertebral fascia. In the carotid sheath is the connective tissue structure occupying a triangular cleft bordered by the visceral compartment medially, the prevertebral fascia posteriorly, and the sternocleidomastoid muscle anteriorly. You can see the cross section here showing the trachea and the esophageal structures in the medially, laterally by the sternocleidomastoid, and posteriorly by the prevertebral fascia. Its contents are common carotid artery, internal jugular vein, vagus nerve, cervical sympathetic chain in the posterior fibers, and the ansa cervicalis in the anterior fibers. Which you can see below. The prevertebral fascia is on the posterior side. Above, you can see the platysma, investing layer of the deep cervical fascia, which holds the anterior jugular vein. Then anterolaterally, you have the sternocleidomastoid muscle. Behind it is the carotid sheath, which holds these contents. As shown, carotid artery, internal jugular vein. In the anterior fibers, you can see the ansa cervicalis on the right side, and posteriorly, you can see the vagus nerve and the sympathetic chain. This is the same picture depicting the carotid sheath with the contents as carotid artery, internal jugular vein, the ansa cervicalis, which is looping in the anterior fibers, and the posteriorly the vagus nerve, and above the sympathetic ganglia. The common carotid artery tussles in the neck medial to the internal jugular vein, and it usually has no branches. It typically bifurcates at the level of the superior border of the thyroid cartilage. Though variations may occur, most often above this level is the bifurcation. The external carotid artery, it supplies the extracranial structures of the head. Its main branches are the superior thyroid, ascending pharyngeal, lingual, facial artery, occipital artery, and the posterior auricular artery. It terminates by dividing into the internal maxillary artery and the superficial temporal artery. Whereas the internal carotid artery runs posterior medially and it enters the carotid canal without giving off any branches. At the carotid bifurcation, there is a carotid body, which is a chemoreceptor, and also a carotid sinus, which is a pressure receptor in the arterial wall. Here you can see the branches of as facial superior thyroid artery just before the bifurcation, the ascending pharyngeal artery, lingual artery, facial artery, posterior auricular artery, and the which is terminating as internal maxillary artery and the superficial temporal arteries. And the internal carotid artery doesn't have any branches. You can see a carotid body at the bifurcation of the carotid artery. The internal and external jugular veins, they lie on either side of the sternocleidomastoid muscle, which they sandwich along this diagonal course. They communicate distally through the retromandibular veins. The external jugular vein, it runs deep to the platysma, while the internal jugular vein lies deep to the sternocleidomastoid muscle. The common facial vein, it typically drains into the internal jugular vein at the level of carotid bifurcation, and it is one of the branches which we ligate on opening the carotid sheath. The cranial nerves 9 to 12 are the one of the closely related nerves to the distal internal carotid artery. In the mid-neck region, the vagus nerve, cervical sympathetic chain, and the ansa cervicalis are within the carotid sheath, and the cutaneous branches of the cervical plexus, which they emerge from the prevertebral fascia posteriorly to the sternocleidomastoid muscle, and they pierce the investing layer of the deep cervical fascia at the posterior border of the sternocleidomastoid muscle. And the brachial plexus nerve roots, they emerge from the anterior and middle scalene muscles, and they lie lateral to the common carotid artery. This is important because these nerves are to be taken care while doing exposure of the carotid artery. Surgical approach depends on which segment of the carotid artery is involved, and the cervical carotid lies superficially, approached via a single anterior cervical incision, whereas the segments near the base of the skull or the thoracic inlet, they might require special maneuvers for adequate vascular control, like sternotomy. The anatomic division of the neck, according to Monson et al., its zone one is divided from the base of the neck to 1 centimeter above the clavicle. This zone may need median sternotomy for proximal control of the vessel. Whereas zone 2 is from 1 centimeter above the clavicle to the angle of the mandible. This is standard anterior cervical incision. And zone 3 is from the angle of mandible to the base of the skull. It may require mandibular subluxation and periauricular extension. For the here we are going to mainly see about the zone 2 exposure of the carotid artery. Positioning of the zone 2 exposure, the neck should be extended, head turned to the opposite side of the incision, and the shoulder should be elevated with the rolled sheet for better extension of the neck. And preparation should be from the upper chest to the lower face of the ear. In case of our sternotomies, we can full draping. Skin incision, a longitudinal incision is given along the anterior border of the sternocleidomastoid muscle from the clavicle to the retromandibular area as depicted in the picture beside. A slight curve should be given below the ear to prevent the injury to the marginal mandibular nerve. Alternatively, if a transverse incision is given, the exposure would be less, but and also the higher risk of injuries for the retromandibular nerve. First, the superficial dissection. Incision is deepened through the platysma, which is the first layer, and then the investing layer of the deep cervical fascia along the anterior border of the sternocleidomastoid muscle. Then the sternocleidomastoid muscle is separated from the underlying vascular sheath by a sharp dissection along the medial border. Then the sternocleidomastoid branch of the superior thyroid artery, which is before the bifurcation, it should be ligated. And the branch of the occipitator artery superiorly, if more distal mobilization is required, then the occipital branch of the is ligated superiorly. And during this dissection, the care should be taken to avoid accessory nerve injury, which will be piercing the sternocleidomastoid muscle in the superior part, that is most above part of the wound. Then retract the sternocleidomastoid muscle posteriorly. Then view will be visible. The carotid sheath will be visible. This is the picture showing the division of the sternocleidomastoid muscle, and it is retracted posteriorly. Then you can see the carotid sheath and the facial vein. Then exposure of the carotid sheath. Then open the carotid sheath above the omohyoid muscle. Divide the muscle if more proximal exposure is needed. The internal jugular vein is dissected free along the anterior border and it is retracted posteriorly along with the sternocleidomastoid muscle. The common facial vein is divided. It usually acts as a trapdoor, exposing the carotid bifurcation. Once the common facial vein is ligated, the carotid bifurcation would be visible easily. The common carotid dissection, isolate the first, common carotid artery should be isolated away from the bifurcation. The vagus nerve usually lies posteriorly to the common carotid artery and occasionally anterior or laterally. Care should be taken to watch for the non-recurrent laryngeal nerve injury, especially on the right side in 0.3 to 0.8% of the cases, which are associated with aortic arch anomalies or the aberrant right subclavian artery. The non-recurrent laryngeal nerve leaves the vagus at the level of carotid bifurcation and is at risk of injury if the dissection is extended either medial to or posterior to the bulb area. Once freed, the common carotid artery is encircled with a vascular loop. Ansa hypoglossal may be divided for better exposure, which is present on the anterior fibers of the carotid sheath. The internal carotid, next comes the internal carotid artery exposure. This lies posterior and medial to the external carotid artery and deep to the internal jugular vein. Dissect it along the medial border of the IJV in the superior wound, which will allow the exposure of the internal carotid artery away from the bifurcation. Then all the small venous branches should be ligated to control the bleeding, and the hypoglossal nerve, which crosses the internal carotid artery in the most proximal part of the wound, it should be identified using the ansa hypoglossal, which loops around the anterior fibers of the carotid sheath. Then it is tethered to the sternocleidomastoid branch of the occipital artery. Dividing this branch would help to mobilize the nerve. Basically, the hypoglossal nerve, which is very close to the sternocleidomastoid branch of the occipital artery. Once freed from all the adhesions, the loop internal carotid artery is looped with an elastic vessel loop. This picture showing the proximal and distal control is obtained before the carotid bifurcation is mobilized. You can see the hypoglossal nerve, which is running very close to the occipital artery. This is one landmark which we can hypoglossal nerve can be identified, and one more is the ansa hypoglossal before dividing. Then comes the external carotid artery exposure. It is identified at the bifurcation and it is looped around it. If the superior thyroid artery arises from the common carotid artery, then it should be isolated. And the superior laryngeal runs behind the external carotid artery, injury should be avoided by encircling the artery at its most proximal point. And dissect it in the periadventitial area to preserve all the nerves. Here you can see the superior laryngeal nerve running behind the external carotid artery. Carotid bifurcation dissection. Dissect the bifurcation area carefully to avoid any embolization in case of carotid artery thrombus. Be aware of carotid sinus nerve, which is nerve of Herring, which acts as a baroreceptor reflex. Overstimulation of this nerve can cause bradycardia and hypotension, and some surgeons would like to inject a local anesthetic or devise the sinus nerve if vagal hyperactivity develops. Once anesthetized, the mobilize the bifurcation completely for the endarterectomy. Uh, then comes the axillary artery. The anatomy of the axillary artery.
Hold on,
It is a
hold on, hold on, hold on. You should also tell us where in cardiac surgery or the exposure of carotid artery is important and why.
Yes, sir. In cardiac surgery, we use it for in pediatrics. We use for cannulations, sir, central cannulations, and in adults, in case of dissections, uh, in when where the arch vessels, we want to stunt the arch vessels and only replace the ascending aorta and hemiarch. In those cases, carotid artery exposure, they are doing carotid, and subclavian bypass, sir. And also, in case of carotid, in pediatric cath labs, when they are using, when they want to do carotid stunting, sometimes they want us to expose the carotid and give. So in all these cases, we are using carotid artery exposures.
One of the most important thing is when you have carotid carotid plaques,
And that,
carotid
yes,
stenosis along with coronary artery bypass. So carotid endarterectomy is one of the commonest procedures that we used to do. So you must know how to do that. Okay. And this thing anyway, that you are only talking about exposure, but you should know where all these things are involved. Carotid endarterectomy is an important procedure for cardiac surgeons. Earlier, we used to do everything, cardiovascular thoracic surgeons, we used to do everything, including the vascular part. But nowadays, you are involved with cannulation, and then you are involved with extra anatomical bypass or debranching procedures, and also carotid endarterectomy. These are the three main things that cardiac surgeons are involved in. Okay.
yes, sir. Yes, sir. Axillary artery anatomy. It is a continuation of the subclavian artery. It begins at the lateral border of the first rib and it ends at the lower border of the teres major, and where it is continued as the brachial artery. It lies within a muscular cleft which is formed by the scapular muscles. Its relations are anteriorly, it's the pectoralis major and minor muscles. Posteriorly, the subscapularis, teres major, and the latissimus dorsi. The medially is by the serratus anterior and laterally by the coracobrachialis and the humerus. It is divided into three parts by the pectoralis minor muscle. So the first part is medial to the muscle, the second part is behind the muscle, and the third part is lateral to the muscle. Here you can see the pectoralis minor pedicle and the axillary artery running. The part medial to it is the first part, second part is behind the teres minor, and the third part is lateral to the pectoralis minor muscle. Its branches, the first part gives rise to superior thoracic artery or to the upper thoracic wall. The second part gives rise to thoracoacromial artery, which supplies the clavicle, acromial process, deltoid, and the pectoral branches. Whereas the lateral thoracic supply, which supplies the pectoral and deltoid regions and the breast. Third part is the subscapular, which gives rise to circumflex scapular and thoracodorsal arteries, anterior and posterior humeral circumflex supplying the scapular region and the shoulder joints. Its relationship with brachial plexus cords usually surround the second part of the artery. Lateral to the artery is the lateral cord, which gives to musculocutaneous and the lateral pectoral nerves. Posterior to the cord is the posterior artery. Posterior cord is posterior to the artery and gives rise to subscapular, thoracodorsal, axillary, and the radial branches. Whereas the medial cord, it is medial to the artery and it gives rise to ulnar, medial cutaneous nerves, and the medial pectoral nerve. The fascia of the axilla, the central compartment of the axilla, it contains the neurovascular bundles, which are neurovascular bundles, lymphatics, lymph nodes, and the fatty areolar tissue, which you can see the image with the fatty areolar tissue and the axillary sheath. The axillary sheath, this surrounds the neurovascular bundles, and the branches of vessels and nerves pass through this sheath into the surrounding fat. Then comes the first plane. This is the clear plane of dissection between the axillary vein sheath and the fat. This is used to identify the neurovascular branches when beginning an axillary dissection. Then comes the second plane, which lies between the fat and the fascia over the serratus anterior muscle. Then the intercostal brachial nerve usually runs through the distal axillary fat and it may need division. Then comes the clavipectoral fascia, which encloses the subclavius muscle and the pectoralis minor muscle, which you can see on the right side. Clavipectoral fascia, which is enclosing the subclavian muscle and the pectoralis minor muscle, which is pierced by the cephalic vein and the thoracodorsal arteries. Thoracoacromial vessels, pectoral nerves, and the cephalic veins are usually pierce the clavipectoral fascia. The outermost layer of the fascia is the deep investing pectoral fascia, which encloses the pectoralis major and the deltoid muscles. It continues between the lateral edge of the muscles and it enters laterally into the axilla, which is called where it is called as the axillary fascia, and it also forms the cleft of the axilla because of its communication. Surgical exposure of for the anatomical sections. The first part, it is extending from the edge of the first rib to the medial border of the pectoralis minor muscle. It is relatively fixed and anterior to the brachial plexus. The second part, it courses behind the pectoralis minor muscle and requires dissection for further exposure. The third part is lateral beyond the pectoralis and it up to the teres major. It is best approached through the lateral incision. In the infraclavicular approach to the first part, the patient's position should be supine and the ipsilateral arm to be abducted up to 90 degrees. It provides laxity for the graft placement in case of any axillary or axillary bypass graftings, and it avoid hyperabduction to prevent brachial plexus traction injury. In layer by layer exposure, a horizontal incision of 2 centimeters is made below middle third of the clavicle, which is 8 centimeter long. And the layers open first is the skin and subcutaneous tissue. Then comes the pectoral fascia. Then split the after pectoral fascia, split the pectoralis major muscle, which is split by bluntly separating its fibers from the length of the all of the length of the wound, which to expose the tough clavipectoral fascia. Once the clavipectoral fascia is visible, inside the fascia to reach the axillary sheath, which encloses the neurovascular bundles and are located in the adipose tissue deep to the clavipectoral fascia, which should be sharply incised. Then, for further exposure, enhancing the exposure, retract the pectoralis minor muscle laterally, avoiding injury to the lateral pectoral nerves. Here you can see the incision made in the infraclavicular region, and the pectoralis minor muscle is being retracted to pectoralis major muscle is dissected and retracted to show the clavipectoral fascia in the first picture. In the second picture, the dissection is further carried out and the clavipectoral fascia is opened for the exposure of the vessels. Artery identification and precautions. The first structure encountered during the dissection is the axillary vein. It should be mobilized and retracted caudally to expose the axillary artery, which lies superior and deep to the vein. Here you can see in the first picture, the axillary vein is being retracted along with the pectoralis minor muscle to expose the axillary artery, which is deep to it. Then mobilize the vein, ligate the small tributaries as needed, and then identify the thoracoacromial artery and preserve it, or may be ligated for better exposure in smaller patients. Preserve the lateral pectoral nerve joining the pectoral branch of the thoracoacromial artery. The precautions are brachial plexus they lie deep to the artery, so they are at risk of injury during the clamp placement. So it should be properly mobilized proximally so that pectoral nerves are not injured and the brachial plexus are not injured, so that it should be looped. Once the artery is freed, encircle it with the vessel loop and lift the artery above the vein and plexus before clamping it. Here you can see the axillary artery is completely mobilized and looped, and then we should apply a clamp to avoid injury to the posteriorly visible cords. Then axillary approach to the second and third parts of the axillary artery. Same, the position is supine with the arm abducted 90 degrees. The incision here is made along the lateral border of the pectoralis major muscle, extending to junction with the biceps muscle. Then it is deepened through the subcutaneous tissue and mobilizing and retracting the pectoralis major muscle medially, as shown in the first picture. The incision is extending along the lateral border of pectoralis major up to the biceps muscle. Then the pectoralis major muscle is retracted and the axillary sheath is visible in the proximal part. Then the exposure, identify the coracobrachialis laterally and pectoralis minor muscle medially. Then the neurovascular bundle usually lies at the posterior border of the coracobrachialis within the sheath. Median nerve is the most superficial structure in the distal arterial sheath, and the artery lies deep to it. So the axillary vein lies medial to the artery. It is separated by the ulnar vein. Here you can, below picture, you can see the median nerve is the first nerve that is visible on opening the axillary sheath, which is retracted along with the coracobrachialis muscle. And then the axillary vein and the axillary vein is, and between the axillary vein and the axillary artery is the ulnar nerve, which is separating it. So the axillary vein lies medial to the artery and it is separated by the ulnar nerve. Dissection is a dissection. Free and elevate third part of the axillary with vascular tapes before clamping it. And for exposure near the lateral wall of the pectoralis major, branches of cords may limit access, so use more proximal exposure. Then the second part exposure, divide the pectoralis minor muscle near the coracoid after identifying and protecting the pectoral nerves. Then they retract the muscle caudally to expose the neuromuscular bundle. The brachial plexus surrounding the artery on three sides, anterior aspect usually remains uncovered, and the thoracoacromial artery should be ligated or divided to enhance to give a better exposure. Here you can see to reach the second part, the pectoralis minor incision is divided close to the coracoid process, and you can see the pedicle in the picture. And this is done to prevent the medial pectoral nerve injury. Uh, then encircle the artery between the divided thoracoacromial branch and junction of the medial and lateral cords, and avoid injury to the lateral thoracic artery during this step. Uh, it is cosmetically good and ideal for the distal axillary artery injuries, and is used for rapid evacuation of the axillary sheath hematomas. The second part exposure. Then the deltopectoral approach to all parts of the axillary artery. To the second and third parts of the axillary arteries, the second and third parts are located deep in relatively narrow incision, and the precise determination of tissue planes necessary in this approach may be impeded by the bloodstream. Despite difficulty, widely used in axillary vascular trauma, gives direct access to all the three parts of the artery. It often serves as extension of the infraclavicular incision. In this, the patient position should be supine, arm should be abducted to 30 degrees and externally rotated. The incision is from the midpoint of the clavicle, extending 5 to 7 centimeters along the anterior border of the deltoid muscle, which you can see the marking here, from the midpoint of the clavicle to the anterior border of the deltoid muscle, which is 5 to 7 centimeters long, and you can see the axillary artery running. And the cephalic vein usually marks the incision site for the deltopectoral approach. Then deepen through the subcutaneous tissue to reach the intermuscular groove, which is between the pectoralis major and the deltoid muscle, which is the deltopectoral groove, which is marked by the cephalic vein as depicted in the picture. Then retract the pectoralis major muscle medially, divide the tendon near the incision if needed for more exposure. Then retract the cephalic vein laterally along with the deltoid, which is shown in the picture. In the second picture, where the deep fascia is opened in the deltopectoral groove and the pectoralis major along with the cephalic vein is retracted medially. Then the underlying clavipectoral fascia and the pectoralis minor becomes visible. Then the third part of axillary artery, it is exposed by incising the clavipectoral fascia along the inferior border of the coracobrachialis muscle up to the coracoid process. Here, the neurovascular bundle lies in this areolar sheath beneath the fascia. The median nerve is the most superficial, as we already discussed. It should be mobilized gently and retracted in the cephalad direction to avoid overtension. And then encircle the artery with vascular tapes after isolating it from the ulnar nerve and the axillary vein. The second part, then transect the pectoralis minor near the coracoid process and identify the pectoral nerves and dissect it. Here, the dissection is same, but only the exposure and the incision is different for this. Then ligate the acromial artery, which lies distal and lateral to the border of the pectoralis minor muscle. The median nerve junction and pectoral nerve loop cross anteriorly, so you avoid injury while dissecting the second part of the axillary artery. Then they isolate the artery between the nerve loop and the cord junction. The lateral thoracic artery must be ligated, may be ligated if it limits the view. Here it shows the pectoralis minor muscle insertion, which is cut, and the looping the second part of the axillary artery by dividing it. Then the first part, which is found proximal to the pectoralis minor, divides the thoracoacromial vessels for better access. Then incides the clavipectoral fascia up to the subclavius muscle. Then the axillary sheath usually lies beneath this fascia in the facti areolar tissue. Then the artery lies deep and cephalad to the axillary vein. Retract the vein caudally. Then you encircle the artery with vascular tapes and lift above the vein and nerves before the clamping bit. Axillary artery
Hold
we
on, hold on,
generally
hold
are
on,
now
hold on.
using for.
Now you have to
Yes, sir.
talk about the indications for subclavian artery and axillary artery.
Yes, sir. The axillary artery we are now using for cannulations in minimal invasive and in case of total arch or badly calcified aortas in case of ascending aorta replacements in and aneurysm of the ascending aortas. In these cases, generally we are using axillary cannulations.
The subclavian artery is divided into three parts. The first part
Yes, sir.
is proximal to the pectoralis minor insertion. So
Yes,
that
sir.
is usually approached by the supraclavicular incision and usually used for subclavian carotid bypasses. Occasionally, you may have to safeguard it when you're doing a thoracic outlet syndrome for neurological problems. But if you have thoracic outlet syndrome for vascular problems, you have to expose the first and the third part of the subclavian to if there is an aneurysm there. And then sometimes you can divide the pectoralis minor, exposing all three parts of the subclavian artery to do an interposition graft. Okay, so you may have to do an infraclavicular approach for third part of subclavian artery and first part of axillary artery. And then if necessary, sometimes you use a combined approach about the supraclavicular and infraclavicular approach to do an interposition graft for an aneurysm of the subclavian artery in case of thoracic outlet syndrome. Of course, you need to know these exposures if there is a vascular trauma, especially if there's a first rib fracture causing subclavian artery injury, then you have to expose the entire subclavian artery. So you may have to do a combined approach of both supraclavicular and infraclavicular approaches. So these are the important things. Axillary artery, most of the time you all use the lateral pectoral muscle incision, but sometimes a deltopectoral exposure may be required if there is an extensive axillary artery injury. Usually happens with road traffic accidents or very commonly with bull gore injuries. The subclavian and the axillary artery are usually injured with bull gore injuries, which we see quite often in our country. Okay.
The femoral artery is the main vessel supplying the blood to the lower limb. It begins at the inguinal ligament, which is a continuation of the external iliac artery. Its location is just medial to the midpoint of the inguinal ligament, and it lies in the femoral sheath. The femoral sheath is a fibrous covering which is enclosing the artery and vein and not the nerve. The lateral part of the femoral sheath is from the iliac fascia, which is the iliopsoas fascia, posteriorly the fascia or the pectineus muscle, and the anteromedially from the transversalis fascia, and the medial side, the femoral canal, which contains the lymphatics and its site for femoral hernia. The femoral canal contains three compartments. The lateral is the femoral artery, intermediate femoral vein, and the medial is the femoral canal. And the lymphatics, it contains the lymphatics, which is site for femoral hernia. The sheath ends at the origin of the deep femoral artery, fusing with the vessel adventitia. Here you can see the same with the posteriorly by the iliac iliopsoas fascia, medially by the pectineus fascia, anteriorly by the transversalis fascia, and medial side you have the femoral canal, which holds the lymphatics. The femoral triangle or the Scarpa's triangle, it is bounded by the laterally by the sartorius muscle, medially by the adductor longus muscle, and the superiorly by the inguinal ligament. And the roof is formed by the fascia lata and its attachments to the inguinal ligament, which is pierced by fossa ovalis for passage of great saphenous vein and the lymphatics. This fossa vallis is covered by the poorly defined cribriform fascia on one of the two groups of superficial. On this, one of the two groups of superficial inguinal subinguinal lymph nodes are present. The more cephalad group of nodes parallel to the inguinal ligament, they lie in the path of the anterior groin incision onto the femoral artery, and rich plexus of lymphatic channels surrounding these nodes. They increase the risk of lymphocyl after incisions in this area. The floor is formed by the iliopsoas laterally and the pectineus muscle medially, and the contents of femoral nerve, artery, vein from lateral to the medial artery. Branches of the femoral artery in the upper thigh, superficial branches and deep branches. Superficial branches are just below the inguinal ligament, which is superficial epigastric artery, which is towards the umbilicus. Superficial circumflex iliac artery along the inguinal ligament. Superficial external pudendal artery, which crosses the femoral vein near the saphenofemoral junction. All pierce the femoral sheath and the fascia lata, which supply the groin, lower abdomen, upper thigh. Veins, all these veins drain into the great saphenous vein. The deep branches, deep external pudendal artery, which supplies the scrotum or the labia. In the deep and the deep femoral artery, which is profunda femoris artery, which is the main branch, which arises 4 centimeter below the inguinal ligament. It gives to median circumflex femoral artery, lateral circumflex femoral artery. The median one supplies the adductors and the hip joint. The lateral one supplies the quadriceps. Descending branch joins the genicular network. And the 4 perforating arteries which pierce the adductor muscle, supplying the hamstrings and femur. Termination, the fourth perforating artery, anastomosis with the popliteal branches. Exposure of the femoral artery in the groin. It's a major access site for coronary and peripheral interventions. It preferred due to large caliber, ability to compress against the femoral head, and direct access to aorta and major branches. The puncture sites in retrograde puncture, it gives access to the aorta, head and neck vessels. Antegrade puncture to the ipsilateral limb, and shorter catheter and lesser radiation is required. Complications are bleeding, hematoma, pseudoaneurysm, lymphocyl, especially if the lymphatics are not ligated while after the incision. The surgical exposure of the common femoral artery, same patient is in supine position. A vertical incision is given up over the femoral pulse, 1/3 above and below, 2/3 below the inguinal ligament, and it is best for wider exposure of the common femoral artery and bifurcation. Then, in case of oblique incision, it is given parallel to the inguinal ligament. It's given above the groin crease. It is preferred for endovascular access and fewer wound complications. And in case of no pulse, slightly medial to the midpoint of the inguinal ligament, used when femoral pulse is not palpable. Dissection step: superficial fascia and subcutaneous tissue encounter and ligate the superficial epigastric, superficial circumflex iliac branches, ligate the lymphatics near the superficial inguinal lodes, which prevents the postoperative lymphocyl. Then incise the fascia lata along the medial margin of the sartorius muscle, and the incision is extended proximally to the level of the inguinal ligament. Retract it laterally to expose the sheath. Once the femoral sheath is exposed, which is a funnel-shaped sheath, and it gives the open it once you open it, it gives access to the artery. Direct access to the common femoral artery is gained by opening the sheath. And then separate the areolar tissue is all that is necessary to encircle the vessel. Take care to avoid the femoral vein, which is medial to the artery. If inflamed or the other end, proceed cautiously to prevent venous injury. Retract the inguinal ligament upward if a proximal control of the femoral artery is required. Here you can see the incision. The subcutaneous once the subcutaneous fat has been removed, the incision after incising the fascia lata along the medial border of the sartorius muscle in the upper picture, and below picture, once the femoral sheath is cut, there gives a direct access to the femoral artery. Branches and relations, it bifurcates into deep profunda femoris artery, it is lateral in origin, 3.5 centimeters below the ligament. The superficial femoral artery, it continues distally through the thigh. Anterior to avoid injury to the profunda femoris artery. And later circumflex vein, it crosses anterior to the profunda origin. So identify and divide if more exposure is needed. And the anatomic variation, the medial circumflex artery may arise from the common femoral artery in 25% of the cases, and lateral circumflex may arise from the common femoral in 20% of the cases. Both must be controlled before arteriotomy to prevent back bleeding.
Yes, see
Here,
once
you
more,
can see
please.
the lateral femoral artery, which is crossing the deep femoral artery, and you can see the profunda femoris artery from the arising from the medial. Uh, Then comes the posterior tibial artery. The vessels of the lower limb, division of the posterior popliteal artery. Just below the soleus, the popliteal artery divides into anterior tibial artery, which passes through the upper interosseous membrane into the anterior compartment of the leg. The tibioperoneal trunk, which further divides into the peroneal artery,
Position
which is the lateral
also.
branch, and the tibial artery, medial branch. The course of the major leg arteries. The anterior tibial artery, it lies on the interosseous membrane. It initially between the tibialis anterior and the external digitorum longus. Lower down between the tibialis anterior and the extensor hallucis longus. Then comes the posterior tibial artery. It lies on the tibialis posterior and flexor digitorum longus, medial to the flexor hallucis longus throughout its case. The peroneal artery, it lies on the interosseous membrane medial to the fibula. It is often covered or embedded within the flexor hallucis longus muscle belly. At the angle, the anterior tibial artery and the deep peroneal nerve, they emerge between the extensor digitorum longus and extensor hallucis longus tendon. They run along the lateral border of the extensor hallucis muscle beneath the deep fascia. The posterior tibial artery and tibial nerve, they course between the flexor digitorum longus, flexor hallucis longus, and pass beneath the flexor retinaculum into the foot, which is the tarsal tunnel. Then the peroneal artery branches, it gives off calcaneal branches posterolaterally beneath the flexor hallucis longus muscle. In the posterior tibial artery, in the proximal exposure, which is usually indicated when when the popliteal artery is obstructed, but the proximal posterior tibial artery is patent. In this, the position is supine, leg is externally rotated and flexed with 60 degrees at knee with a lateral support. Incision is 2 centimeters behind the posterior border of the tibia, just below the knee, extending 10 to 15 centimeters distally. Incise through the subcutaneous tissue, avoid the saphenous vein injury which runs along this course. Then divide the deep fascia to expose the medial gastrocnemius muscle. Once the gastrocnemius muscle is visible, retract it posteriorly to expose the distal popliteal vessels that penetrate the soleus muscle. Here you can see in the upper picture, the gastrocnemius muscle is divided and it is exposed, it is medially retracted to expose the tibial arteries, which is piercing the soleus muscle. Then sharply divide the tibial attachment of the soleus muscle over a right angle clamp to prevent the vessel injury. Then identify the tibioperoneal trunk and its bifurcation. Isolate it proximal to the posterior tibial artery for bypass. Then accompanying veins are paired and sometimes multiple. A complex interval connecting network of venous branches overlying arteries may be present. They should be carefully divided during arterial dissection. Here, the second picture shows the division of the soleus muscle at its origin, and it should be done over a right angle loop to prevent the vessels which are underlying the soleus muscle. In the mid-leg exposure for the posterior tibial artery, the position is supine, leg is externally rotated and flexed 60 degrees at knee with a lateral support. Its incision is 2 centimeter behind the posterior margin of tibia up to 10 centimeters in length. Then divide the subcutaneous tissue and the crural fascia. Divide the tibial attachments of the soleus, retract it posteriorly, and then you develop a plane between the flexor digitorum longus and the soleus muscle. The artery lies on the posterior surface of the tibialis posterior in the loose areolar tissue. And divide and ligate it surrounding the venous plexus branches and to free the artery. Here you can see the cross section where the flexor digitorum longus and the flexor hallucis longus, and you can see the posterior tibial artery lying behind the tibialis flexor digitorum longus muscle. Exposure of the posterior tibial artery at the ankle. Clinical use. Long vein bypasses to the posterior tibial artery at the ankle show patency rates comparable to proximal infrageniculate bypasses. Its similar patency rate is present. So superficial location makes it easy and a preferred site for distal bypass. And also in our cases, perfusion cannulas in distal perfusion cannulas are inserted through the posterior tibial artery in peripheral ECMOs. Patient positioning and preparation, patient supine position, externally rotated and knee flexed at 60 degrees. And then incision, a vertical incision of 1 centimeter is given posterior to the distal tibia. between the medial malleolus and the posterior gastrocnemius tendon. Then this incision is curved along the medial malleolus onto the medial side of the foot. Dissection steps. First, divide the flexor retinaculum to expose the tarsal tunnel consent. The neurovascular bundle lies in the groove between the flexor digitorum longus tendon and the flexor hallucis longus tendon. Then identify the structures. The posterior tibial artery lies anterior to the tibial nerve at this level. Mobilize and retract the flexor digitorum longus tendon anteriorly to isolate the artery for bypass and anastomosis. Thank you.
Yeah. For cardiac surgeons, the exposure of the femoral artery is very important, especially when you have to do peripheral cannulation for bypasses. Again, you should talk about the pros and cons of vertical exposure versus a horizontal or an oblique exposure. Oblique exposure cosmetically is better as well as healing is better, whereas a vertical exposure gives you access to the entire length of the femoral artery, depending on if you have a diseased artery or a diseased this thing proximally, you can extend it upwards to the external iliac or downwards to the profunda. Now, exposure of the profunda is very important, and usually it is deep seated. And the best way to expose the profunda is from the reverse technique, the loop the profunda common femoral artery and then do the subtraction technique for looping the profunda artery. You didn't talk anything about the adductor canal, which is an important exposure area when you're doing the femoropopliteal bypass, and also the posterior approach for the popliteal artery, especially in cases of trauma and posterior dislocation of the knee, which causes a lot of problems there. And posterior approach is usually done there. And one very important thing whenever you're doing a bypass surgery on any of these arteries, if they are crossing a joint, you must always use a ringed PTFE graft, not a straight plain graft. You must always use a ringed PTFE graft if you're crossing a joint, either iliofemoral or at the hip joint or femoropopliteal at the knee joint, and axillary artery or even the neck, so that there is no kinking of the graft. So these are important things that you have to know. And there is a very nice book called Anatomic Exposure of All the Arteries. I don't know if you have read that or seen that, or many of your
This is
pictures may have come from that. And
this is
it is,
from that book.
sorry?
All the material is from same book.
Yeah. So I think all of you should keep this book in your phone, a PDF version of this in your phone, because we don't use these exposures very often and very difficult. And it's always nice to have a ready reckoner whenever you are faced with a problem, especially when you're treating trauma. As I said before, when we trained, Jara sir and me will remember that we used to do cardio, thoracic, and vascular surgery. So we had to be aware of all these exposures at times. So we had to do the entire vascular tree from top to bottom. But nowadays, of course, vascular surgery is a separate department, as well as thoracic surgery has also become a separate field. So, but still, it is important for you all to know the exposure of this. As I said, carotid artery is important with the carotid endarterectomies. Then axillary artery and subclavian artery for thoracic outlet syndrome and peripheral cannulation, femoral artery for peripheral cannulation and ECMO. So these are important things. It's something that you should have as a ready reckoner available with you all the time. maybe you can download this book into your phone or put it into your drives, personal drives, so that you can access it anytime, anywhere. I see Rahul there. Rahul, any comments?
Morning, sir.
Morning.
Yeah, no, I don't know who chose this topic, but I'm very glad they did this because now previously it used to be like my concern is about people, the residents who are on duty and what they can do and to what extent they can handle a situation. So for me, anybody who is doing a duty should know how to go on pump or open the chest and go on pump at least once they cross third year training or once they are third year or fourth year. So that is a real asset because sometimes you have multiple calls from different locations and the seniors might be on busy at something. But I think this is one more additional thing if the most of the people are aware, not just to do it yourself, but even to assist because many times now you are expected to expose the from peripheral vessels even when you are on call. So if you are even if you are a second year or a first year or whatever, if you know how to assist somebody to expose the vessel, you are really helping the person who is actually doing the primary job. So that way, I felt this topic was very relevant, and uh, it's good that Navya did it. The only one question I had is any role of this peripheral cannulations in pediatric setup? That's one question I had now for Navya.
Peripheral cannulation, femorals, no, sir. Carotid, yes, sir. Carotid, Sudesh sir does for mostly redo cases, he prefers doing a carotid cannulation, sir, if it's very small baby.
Okay, we are talking only about NH. There's a lot of things are
Yes.
happening all over the world. Have you read about anything happening uh, about peripheral cannulation and what people are trying to do? Because generally, like you said, our mindset is always, pediatric subset, smaller size, so you wouldn't want to touch the peripheral vessel. But just read up about it and tell me. There are newer techniques where they are getting smaller cannula, I think. And they are because now with all this hype and everybody jumping up and down about robotics and all that, there is slow advancement in peripheral cannulations in pediatric setup also. Just to do
Okay,
some
sir.
homework and just like
Okay, sir, I'll let you.
yeah.
Any comments, sir?
No, it's a very good presentation, especially about the exposure of the carotid body, carotid external and internal carotid artery. Now, the way to identify whether it's external or internal carotid artery, the main thing is it's a medial, the internal is lateral and more posterior, and most important thing, the branching. That's how we identify the external carotid artery because of the branching pattern. So actually, for carotid endarterectomy, it's absolutely important to loop the external, internal, and common carotid artery. That you did very well. Uh, spoke everything about that. About the axillary artery, you mentioned everything about how to expose the first part, the second part, and the third part of the axillary artery. It's so commonly used for cardiopulmonary bypass now. And you didn't mention that it's not a direct cannulation because a direct cannulation it may kink actually, and so you usually put a graft. If it's an
Yes, sir,
adult,
side and
8
cross.
millimeter graft, and the cannula is put in the graft, so that it's lying outside the wound, and the thinking of that doesn't occur, and the pump pressure doesn't go up. So that you didn't mention. Then the subclavian artery, you didn't completely say anything about the exposure. The left subclavian artery is mainly exposed in its proximal part by a left thoracotomy. And the right subclavian artery, along with the nominate, can be exposed very well with a upper median stenotomy, and if necessary, by a lateral incision above the right clavicle. So this is important, as Krishna said, when you got a cervical rib or thoracic inlet syndrome and the blockage of the subclavian or aneurysm or clot, from which multiple clots uh, disintegrate and come and block the arteries in the hand. So that approach is done for the subclavian artery. Then femoral, you did fairly good, but you didn't say that the femoral canal then leads into the adductor canal, the or subsartorial canal, or what our time used to call the hunter's canal. So much so, a FEMPOP can be done without approaching the popliteal by changing the position, because you can get that popliteal artery in the same position of the patient with slight rotation of the knee, And the other exposure of the uh, other distal arteries are not done nowadays because no graft will stay patent in those regions, and actually all the vascular surgeons have taken over for angioplasty and stenting, all those things, because as Krishna said, the FEMPOP, if it crosses a joint, the chance of blockage is much more. So, and the most important thing, you didn't mention anything about the exposure of the radial artery, because you always have, not for treatment, but for a bypass graft as a radial, as a second or third graft you want to use. So that you must say completely where the incision, from where to where, how you retract the brachioradialis to the lateral side and the flexor carpi to the lateral side, and then get into and there's some cutaneous nerve, the lateral medial and the brachial cutaneous nerve, the superficial radial nerve, because if you cut those nerves, the patient gets a paresthesia after surgery. So you should have spent some time in telling us how to expose the radial artery for, and the tests done. That may be another topic actually, which are the tests you do, patency of the ulnar and the palmar arch. Otherwise, good presentation.
Maybe we could have a class on all the arterial conduits and how to expose, how to harvest them. The IMA, the bilateral IMA, the radial artery, the gastroepiploic artery, and all those various things. Maybe that could be also used as a reason, because these are practical things that you have to do day to day, and you must really know how to do that, and what are the problems that are encountered, and how to avoid or encounter these problems.
And also the anatomical and extra anatomical bypass class.
Bypasses, yes.
In very old people who were otherwise not fit for major surgery, the axillofemoral, the crossover femoral, the carotid subclavian, carotid to carotid, and also those same thing done for TEVA, thoracic endovascular aneurysm repair. Before that, you do this procedure so that you can do a TEVA procedure. Okay, all right.
Okay. Thank you, sir. Thank you, Rahul.
Thank you.
And thank you,
Thank you.
Navya.
Thank you.
Thank you.